start our next topic, that is hemodynamic monitoring and fluid therapy by Dr. S. Samaddar, Chief of Critical Care and Anesthesia, Tata Main Hospital, Jamshedpur. I do invite Chairperson Dr. Rajesh Verma, Associate Professor PMCH, Dr. U. Badani, HOD Anesthesia, AIMS, Patna, and Dr. Jamal Ashraf, well-known physician from Palace Hospital.
Good morning, ladies and gentlemen. At the outset, I'd like to thank the organizers of this conference, particularly Dr. Deepak, Dr. Kishore, for inviting me and giving me this opportunity to deliver a talk on hemodynamic monitoring and fluid therapy. My approach to this problem or this topic will be how a fluid therapy can be facilitated by hemodynamic monitoring. Now, fluid therapy is one of the most important strategy or mainstay of treatment that is adopted in any critical care setup, even outside the critical care setup. And it alone can reduce the global tissue hypoxia and prevent the multi-organ dysfunction to a great extent. While giving fluid load to the patient, our focus always remains on the intravascular compartment. On the intravascular compartment, without ignoring the interstitial compartment or intercellular compartment. The intravascular compartment is the most dynamic compartment, and this ensures the oxygenated blood and proper perfusion to the vital organs and to the tissues as per their need. If this compartment remains underloaded or overloaded, then there are obvious problems that all of us know. But when we are doing hemodynamic optimization, it should be done early before the patient develops organ failure. So once the patient develops organ failure, further optimization might not give us a good result, and therefore early optimization is mandatory. Now the question is how to optimize the intravascular volume and the hemodynamic status of the patient. It is not the fluid that is present in the intravascular compartment. How effective this fluid present in the intravascular compartment is that matters. Whether the suppression is good enough or not and the perfusion is good enough or not to satisfy the oxygen demand of the tissue, that is important. So the study that tells us about the blood flow and the effectivity of the suppression, that is known as hemodynamic monitoring. And when we are managing the patients, we select parameters. What are the parameters that will help us in identifying this effectivity of the circulation? We set the targets, we decide our action plan, and then we see whether this action plan and the selected parameters have given us result or not. If we go by the studies that had been conducted in the past, Shoemaker had proposed this hemodynamic maximized oxygen delivery concept. They selected the DO2 cardiac index as the parameter to optimize the patient, and they claimed that it gives result, reduce the mortality in sepsis, trauma in operated patients. But this was challenged because of the flaw in the study. Calculation of DO2 is difficult, predicting the critical DO2 in critically ill patient also is difficult. Almost 20 years down the line, again, Sandham et al. In 2003 had conducted the study, and they had taken the almost similar parameter. They also depended on the oxygen delivery parameters. Apart from the PCWP in the PA catheter group, in non-PA catheter group, that was the control group, and they also depended on the mean arterial pressure, the hematocrit value, and they found that in the PA group and with the DO2 being taken as a parameter to optimize the patient's condition did not give much result. Early goal-directed therapy in 2001, a single center study promoted by Rivers et al., where they depended on the CVP monitoring. They also monitored the mean arterial pressure, the supravenous oxygen saturation, and they decided their action plan to get the result. They claimed 30% reduction in the mortality. Now this, if we go by the survey, there are few takers in these three countries, and the reasons for not using early goal-directed therapy is lack of availability of monitoring tools, lack of experience with instrument, and few subset of respondents also felt that it doesn't help. And this perception was objectively confirmed in the process trial which was published in 2014, where they found that the early goal-directed therapy mortality was higher as compared to the relatively non-protocolized. The protocol was a little different than the early goal-directed therapy, and the usual care which was dependent on the clinician's wish. And there they found that the mortality was lesser than the early goal-directed therapy, and they claimed that there is no benefit with mandated use of central venous aspiration and central hemodynamic monitoring in all patients. Now, Cerebral Sepsis Campaign Group, who supported the reverse study, early goal-directed therapy, and they said that they will like to wait for the further two trials, the ARISE and PROMISE trial to be published before they take their decision and they amend the bundle element that is being promoted currently. Now, if we go by the actual observation about hemodynamic monitoring, the parameters that had been selected in all the studies, the central venous pressure, oxygen delivery, the mean arterial pressure, blood lactate, all these things, questions were raised, issues were raised, and therefore we are left with the question that what is the parameter, what should be the selected parameters. Now, if you go by the NICE guideline 2013, again the systolic blood pressure, the criteria, heart rate, capillary fill time, all these are indication for urgent fluid replacement. So we are actually, though these parameters are being challenged, being questioned, but we are depending on this parameter. And if we go by the 2012 Khalid and his colleagues publication, there also they have selected almost the similar type of parameters to decide whether the patient is actually cardiorespiratory system-wise unstable or not. The question therefore was raised, very pertinent question was raised in 2003 by Deloma et al. That the way we are managing the patient in developed countries and we the followers in the developing countries, are we doing the right thing or not? Though there is strong consensus in favor of the hemodynamic monitoring, particularly invasive monitoring, there is very little validation of these hemodynamic monitoring tools and the parameters that we are using. Now, one thing is very clear. Whatever monitoring we do, that is not going to bring a physiological change unless until that is backed by action plan. We should select the right parameter, the right target, right action plan, then only we can get result. Then the question is of accuracy and precision of the monitoring, whether there is a drift or not, can it give us constantly reliable result or not, the complication associated with the invasive monitoring in particular, and the limitations of all monitoring tools or monitored parameters that we must know. Now, if we broadly divide the parameters, then there are two types of parameters, that is upstream parameter, all the variables that decide the DO2. This includes the central venous pressure, this decides the contractility of the myocardium, this includes the mean arterial pressure, the systolic blood pressure, diastolic blood pressure, the oxygen content, the DO2, everything that decides the oxygen delivery to the target organs, the tissues. All these parameters are upstream parameter, and all the variables that tells us how effective this DO2 is in oxygenating the tissues, those are downstream parameters. Now, the main difference between the upstream and downstream parameters again are that the upstream parameter you can intervene, you can bring a change, you can improve the blood pressure, you can bring a change in the central venous pressure, you can improve the hemoglobin concentration, you can increase the oxygen content. So all these interventions are possible with the upstream parameter, but downstream parameters we are mainly monitoring. There we cannot bring a change. We are trying to evaluate with the measures that have been taken to bring a change in the upstream parameter that is making a positive impact on the downstream parameters or not. The effectivity of the circulation there or not, tissue oxygenation is maintained or not, that we try to find out. Now, our approach while managing these patients and monitoring this patient is to have a stepwise approach where we depend on the clinical assessment, basic monitoring, preload monitoring and fluid responsiveness. Advanced monitoring includes cardiac output, assessment of cardiac contractility and assessment of tissue perfusion, which also can be done at the patient bedside to some extent, and advanced techniques also are there. Now, clinical assessment is repetitive. It doesn't need any particular setup, particular equipment or instrument, and therefore we should always rely on this. It should always be done. This tells us and actually guides us whether the patient's condition is getting deteriorated or not. First, poor peripheral pulse, impaired capillary refill, all the global parameter, cold extremities in particular tells us about the peripheral resistance. The perfusion is not good to the extremities. Tachycardia, tachypnea, all this tells us that the hemodynamic system is getting is not in the perfect condition. The regional parameter, where in absence of any neurological problem, patient who is awake is not confused, suggests that the cerebral perfusion is good. If the ischemic chest pain is there, that tells us that there is imbalance between myocardial oxygen supply and demand. Altered skin perfusion tells that the skin perfusion is not good if there is mottling, and oliguria in absence of again a renal problem tells us that the renal perfusion is not good. Mottling in particular can be scored, and it starts usually in the patellar region, and when it spreads, based on that, the spread, we can score the patient from 0 to 5 on the score, and if the score is higher, the patient is in a serious condition. Now, basic monitoring, we do rely on the blood pressure monitoring, which could be auscultatory method, it could be non-invasive blood pressure monitoring, it could be intra-arterial blood pressure monitoring, invasive monitoring. The ECG, the pulse oximetry, baseline serum lactate, and very many biochemical variables also we monitor. I'll be spending some time on the blood pressure monitoring because in almost all the studies, all the guidelines will find that the blood pressure, particularly the mean arterial pressure targets are given. Now, the blood pressure, though it is very commonly monitored parameter, but it is the most unreliable measurement in modern medicine that has been claimed by Paul L. Marino in the ICU book. Now, what information do we get from this? The pressure head, that is systolic blood pressure, the impedance, that is diastolic blood pressure, the perfusion, that is mean arterial pressure. Now, when we are auscultating a patient, we depend on correct of sound to decide what is the blood pressure. Now, the frequency of correct of sound is 25 to 50 Hz. The frequency of optimal hearing is 2000 to 3000 Hz. Now, appreciate the gap that is present in a busy ICU setup where a lot of noises also might be there, alarms might be actually ringing. In that situation, appreciating correct of sound could be difficult. Size of the cuff, what is the manometer level, rate of fall of mercury column, site of measurement, all this matters. And therefore, when vascular impedance is abnormal, patient in shock, peripheries are cold, just maintained blood pressure doesn't mean that the perfusion is there. So there is a wide gap between maintenance of pressure and the perfusion the patient might be having. So we are interested in perfusion, we are not interested in mere maintenance of blood pressure. That should be very well appreciated. Then mean arterial pressure is an approximate of organ perfusion, and it is considered to be cornerstone of hemodynamic assessment. Now, how does is it being calculated? Diastolic blood pressure plus 1/3 the pulse pressure. Now, this calculation is true when the patient is not in tachycardia, there is no tachycardia. But most of the patients who are unstable, they are having tachycardia. So in that situation, diastolic phase will be reduced, and this kind of calculation can give us erroneous result. And tissue hypoperfusion can be present when the patient blood pressure is normal. Even with high blood pressure also tissue hyperperfusion is possible. So therefore, it is not only fall in blood pressure that determines that perfusion is less, and therefore always correlating blood pressure with the perfusion in critical case setup, when we are doing so, we should be very judicious and justified. Now, we also use NIBP monitoring, that is oscillometric method of monitoring the blood pressure. Maximum oscillation is appreciated by these instruments and equipment, and that maximum oscillation is considered to be mean arterial pressure, and from there that mean arterial pressure calculation, based on the algorithm that this equipment has, the systolic blood pressure and diastolic blood pressure is calculated, and diastolic blood pressure is the most unreliable measure by the oscillometric method. The new automatic devices, the NIBPs, where when we accept their performance level, the difference of plus minus 5 mm of mercury with a deviation of 8 mm is considered to be normal. That means up to 20 mm of mercury deviation from the true pressure is possible, and still we will be considering that the equipment is functioning normally. Now this is the oscillation that is being monitored. This is the mean arterial pressure and the systolic blood pressure and the diastolic blood pressure. Now this oscillometric method underestimates the systolic blood pressure and overestimates the diastolic blood pressure. And also underestimate mean value during hypertension and overestimate during hypotension. And where we are most concerned, that means the patient's blood pressure might be lower than what is being reflected in the NIBP. Another situation where patient is supine, the intra-arterial or invasive blood pressure or NIBP could be same, but when the patient is given right lateral, left lateral tilt, in this situation has been given a right lateral tilt, if the cuff is tied on the right arm, there is almost 20 centimeter gap between the heart level and the cuff level, and you can get a higher BP, almost 15 millimeter of more higher systolic blood pressure, diastolic blood pressure you can get. And if the cuff is on the left arm, then you will get almost 15 millimeter of lower blood pressure than the intra-arterial blood pressure. So all these things should be taken into consideration because we are depending so heavily on the blood pressure to decide whether the patient is hemodynamically stable or not, and our action plan is also being decided based on the blood pressure that we are monitoring. Then whether the 65 millimeter of mercury mean arterial pressure is good enough or not. This could be good enough in the non-hypertensive patient, but in hypertensive patient a higher MEP might be needed. There is no firm data supporting any one limit of arterial pressure or cardiac output. Accordingly, empiricism is the rule regarding target values of both MEP and cardiac output. So the key points here are that there is no gold standard for BP measurement. Pressure doesn't equate flow. Maintained BP doesn't mean maintained perfusion. Fall of BP indicates decompensation. Pain is more important than a single value. Now about invasive monitoring, this is equipment intensive, costly, technically challenging, error prone because there could be calibration, labeling and zero setting related errors. The system could be under dampened, which can be appreciated by the multiple oscillations. If there is less than one oscillation, then it is over dampened, and here you can get a high systolic blood pressure, the diastolic blood pressure could be lower normal, the pulse pressure is wide, here pulse pressure is narrow. But the advantage is that the mean arterial pressure in both the situation will be similar, so you can rely on the mean arterial pressure. Now whether the system is again ready to monitor the patient or not, that can be justified by finding out the amplitude ratio, that is the first oscillation and the second oscillations ratio. Second oscillation divided by first oscillations height, that gives us amplitude ratio. From there, the damping coefficient can be calculated. If you fit this amplitude ratio on this graph, you will get the amplitude ratio, damping coefficient. And if this is less than 0.4 to 0.5, which is normal value, then that suggests that the system is actually under damped, and therefore as the situation here is multiple oscillations will be there and the system will not be giving you the correct reading. There is no physical sign or hemodynamic value which absolutely tells us that there is patient is in circulatory shock. The diagnosis should not be ruled out if a single finding like patient is not hypotensive or patient lactic acid level is normal, that means patient is not hyperperfused or not in shock, that assumption also should not be drawn. Now preload and fluid responsiveness, that is the third stage. Preload is the end diastolic wall tension or the fiber length of the ventricle. Now we cannot monitor the wall tension or the fiber length, so we depend on the volume or the pressure. Now central venous pressure is the indirect measure of this preload, but this is a very poor predictor of fluid responsiveness. The normal CEP is 0 to 5 millimeter of mercury in spontaneously breathing patient. Upper limit in ventilated patient 10 millimeter of mercury. More than 15 millimeter of mercury is considered to be abnormal. There should not be any discordance between the right ventricle, left ventricle, the intrathoracic pressure rise and intra-abdominal pressure rise also can influence the central venous pressure monitoring. So all these things should be taken into consideration when we are relying on the central venous pressure monitoring. Now a low CVP, does it necessarily mean that the patient is fluid responsive? You give fluid to the patient. Many patients where particularly the capillary permeability is high, you give fluid, the patient might not respond to the fluid load given. And patients who are having right ventricular infarct, their CV could be high, and still these patients could be fluid responsive. You give fluid to the patient and the cardiac performance will improve. So what should we monitor? The pressure or the volume? Volume definitely is better, but pressure monitoring is easier. So depending upon the situation, the condition, we can rely, but knowing the limitations of the pressure-based monitoring of the preload. Now in the CVP, the volume monitoring, we have the static measurement that is being done by global industry volume, left ventricular industry volume, by the transthoracic thermodilation methods that we will be discussing, and there are dynamic methods which are better methods to be to assess the preload and fluid responsiveness that we will be discussing now on. The transpulmonary thermodilation like PICO and volume view method can tell us about the volume status of particularly the extravascular lung water. That is very important parameter that we can monitor with this. But other parameters like interthoracic thermal volume, pulmonary thermal volume, the global endoscopic volume, all this can be monitored, and I will be concentrating on the extravascular lung water in particular, which can be found out by detecting the interthoracic blood volume from the interthoracic thermal volume. Interthoracic thermal volume is the blood volume present in the thoracic cavity as a whole, and here and in the interthoracic blood volume, the lung water has not been included. So when from the interthoracic thermal volume, the interthoracic blood volume is detected, we get extravascular lung water, and this tells us whether the patient is having pulmonary edema or not. The normal value is 3 to 7 ml per kg of body weight, and it can help us in guiding the fluid therapy. The other parameter that we can calculate is pulmonary vascular permeability index, which is extravascular lung water divided by the pulmonary thermal volume. And if normal value is 1 to 3, if this is higher, then that tells that the capillary permeability is higher and fluid will be oozing out into the interstitial compartment. Now, what is the fluid responsiveness? When we are giving fluid therapy to the patient, we are always in a dilemma. If I give fluid to the patient, whether the cardiac performance will improve or not. By definition, fluid responsiveness means that increase in cardiac output by 15% from the baseline. Now this can be done by a fluid challenge. 500 ml of crystalloid or 250 ml of colloid being given over 10 to 15 minutes of time, and then we try to observe what is the change in the CVP to find out the compliance of the venous system, and also the cardiac performance, where we can rely on the blood pressure, heart rate if the patient is in the ward situation, or when we do not have sophisticated monitoring technique. The stroke volume or cardiac output are better monitors, and then if the patient is responding to the fluid therapy and positive response is there in the cardiac performance, that means the patient is on the steep portion of the Frank-Starling curve, and patient can be given fluid load if that is needed. But when we are giving fluid, there is always a possibility that patient can be overloaded with the fluid load that we are giving, and that could be detrimental for the patient. So if by any means we can auto-transfuse the patient, that means the volume that already is present in the body, that is put into the effective circulation, and this volume is used as a fluid challenge for the heart, then it is better because this is reversible. Now this is used for in the passive leg raising maneuver. The same principle is adopted, where the foot end and the whole lower limb is elevated by 45 degrees, kept for 1 minute of time, and then we try to find out the positive response on the cardiac performance. The other thing that we can do in a spontaneously breathing patient, in particular the ventilated patient also, it can be done. That is, what is the collapsibility or distendability of the inferior vena cava or the superior vena cava. During spontaneous breathing, if the patient is volume depleted, then during inspiration we will find that it is the inferior vena cava is getting collapsed. And if patient is being ventilated, during normal or hypervolemic situation, the IVC will not distend, but if this patient is hypovolemic, this will get distended. So this tells that the patient is needs fluid, and fluid challenge can be given to this patient. Now it can be monitored. The diameter of the inferior vena cava can be monitored. If this is less than 2 cm and more than 50% collapsibility during inspiration in a spontaneous breathing patient is there, then the patient can be given more fluid. If it is more than 2 centimeter diameter and less than 50% collapsibility, then we should not give fluid. And this can be correlated with the right atrial pressure or the central venous pressure. That means if more than 50% collapsibility is there, then probably the CVP or the right atrial pressure is less than 10 millimeter of mercury, and a fluid load is justified in this situation. This is how the diameter is monitored by ultrasound, and during inspiration, the collapsibility can be the diameter can be monitored like this. Distendability index is another parameter that we can find out by the maximum collapsibility and the minimum, the maximum diameter and the minimum diameter, and the distensibility index can be calculated from that. If it is more than 18%, then that suggests that the patient is fluid responsive. Now, dynamic preload assessment when the patient is being ventilated. Now, principle here is that when there is intracranial pressure changes are taking place, during inspiration and expiration, the cardiac output varies. During inspiration it is more, during expiration it is less. And this principle, if we can find out this variation, and this variation is exaggerated, then we consider that the patient is fluid responsive. If the patient is on ventilator, there are multiple parameters where this principle is being used, like pulse pressure variation, the systolic pressure variation, and stroke volume variation. Here, when during inspiratory phase, the pulse pressure is calculated, and during expiration the pulse pressure, which is narrower, based on these two variables, the PPP percentage can be calculated, and if it exceeds 13 to 17%, then the patient is fluid responsive, more fluid should be given to the patient. But there are certain limitations and prerequisites that patient should be in sinus rhythm, no spontaneous pressure should be there, no right-sided heart failure, and tidal volume should be more than 80 ml per kg of body weight. And the low tidal volume that just now had been discussed, in that situation the fluctuation will be less, so therefore we might not appreciate whether the patient is fluid responsive or not. The same principle is applied by the pulse oximeter plethysmography, where again fluctuation during inspiration and expiration takes place, and by the same type of formula we can find out what is the plethysmographic index, and if this index is again more than 13 to 17%, the patient is fluid responsive and the patient can be given fluid. The systolic pressure variation is another method by which the same principle remaining the same. If the variation is more than 10 millimeter of mercury, then patient is fluid sensitive and more fluid can be given, but it is less sensitive and specific than the pulse pressure variation. This is how we can find out the systolic pressure variation, and if this is the variation is more than 10 millimeter of mercury, then we consider that the patient is fluid responsive. Systolic pressure variation has been found. If it is more than 15 millimeter of mercury variation is there, then it predicts a low pulmonary capillary wedge pressure. Without the pulmonary capillary wedge pressure being monitored, we can draw a conclusion that the patient's the preload is less, and it is a better predictor of preload than pulmonary capillary wedge pressure. So it is less invasive, and we can find out whether the patient is fluid responsive, the preload is less or not. The stroke volume variation, where again principle remaining the same, the arterial waveform analysis is done. This can be done by the Vigilio technique or flow track, the PICO, LITCO, all these techniques are available where arterial waveform analysis is being done. Esophageal Doppler can be used, or echocardiography technique also can be used to find out whether stroke volume variation is taking place or not. And if it is more than 10%, again the patient is fluid responsive and fluid can be given to the patient. Now, this appears theoretically at least that this is better than pulse pressure variation, but clinical studies have not shown so, and pulse pressure variation, which is an easier option, can always be tried to find out the patient's fluid responsiveness and the preload assessment. Ratio of PPV and stroke volume variation, which again, if it is more than 12 to 13%, then it is abnormal, which shows that patients who will not increase their BP in response to a fluid challenge despite increasing cardiac output. In a meta-analysis of 29 studies, Mike et al. They have found that the systolic pressure variation, pulse pressure variation, and stroke volume variations are better in predicting changes in cardiac stroke index in response to a fluid challenge than all the static variables like PCWP or CVP. Now, when you have found out that the patient is fluid responsive, is it necessary that the patient should be given fluid? That is not so. If the patient, there is no evidence of hypoperfusion, despite patient being fluid responsive, we should not give fluid. So that is mandatory because normal patient is in the steep portion of the Frank-Starling curve. So if based on the fluid responsiveness we want to give fluid, then everyone, all of us who are sitting here should be given fluid. So that should not be done. Now, the cardiac output assessment, which I will not be going into further details. The pulmonary thermodilation, which is the gold standard, it is very invasive. Pico, volume view, relatively less invasive, but drift is present. The LITCO, where lithium is being used, here the principle pulmonary thermodilation, transpulmonary thermodilation, the principle remains the same. Here the lithium is being used as an indicator. Arterial pressure waveform analysis can be done with Pico, LITCO, flow track to find out the stroke volume and the fluid responsiveness of the patient. Esophageal Doppler can be used. Then echocardiography, TPE and TOE, the transesophageal echocardiography can be used. Now, esophageal Doppler in particular, it is quite popular in UK, in USA, New Zealand and Australia. It is not all that popular. NICO, that is applied field principle, where carbon dioxide breathing is being used to find out what is the cardiac output. Bioimpedance and bioreactance, which are more or less the same. These are not that frequently used in critical care setup because they have not given their clinical results are not supportive. Now, cardiac contractility assessment, that is another next step of assessing the patient, where ejection fraction can be calculated. We know the formula. If it is more than 55% is considered to be normal, mild impairment less than 54%, less than 44%, moderate impairment, and severe impairment less than 30%. This also can be found out by the steep portion of the arterial waveform. If it is very steep, then the contractility is good. And also by DPDT max monitoring, which can be done by placing a microcatheter in the left ventricle, and also by the mitral through the mitral valve, the regurgitant flow can also be monitored, and that tells us during the isovolumic contraction, where the left atrial pressure is not changing and the ventricle is contracting, the regurgitant flow through the mitral valve can be monitored, and that we can find out what is the DPDT max or the contractility of the left ventricle. For right ventricle also similar thing can be done, and if it is the normal value is 32 mm of mercury per second. For right ventricle it is around 12 mm of mercury per second. Now lastly, the assessment of tissue perfusion and microcirculation, where clinical examination gives us a lot of information. As already I have told you that if there is hypoperfusion and patient is for renal perfusion assessment, if the patient is awake, not confused, then probably the cerebral perfusion is good. If patient is putting good urine output, then the renal circulation is good. If there is no distension and no the coffee ground aspirate is not there, probably the gut perfusion is good. So this kind of assumption can be drawn by the clinical assessment. The arterial blood pressure also tells us about if we can rely to taking into consideration the limitations of arterial blood pressure. If we can rely on this, then that also tells us to some extent that the renal perfusion should be good. Urine output I have already talked about. Serum lactate, base deficit, supravenacle saturation. It has been criticized a lot, particularly in sepsis patient, but it is one of the parameter that is considered to be important. Even Survival Sepsis Campaign Guideline also had promoted this, despite the limitation it has in assessing the patient, particularly in sepsis patient. There are certain advanced techniques which are not being used very routinely in clinical practice because they have not proved their worth in clinical practice, like polarization spectral, side-stream dark field, and near infrared spectroscopy. So the current status is not supporting these newer techniques. Now to conclude, the hemodynamic monitoring per se has no favorable impact on the outcome. It's the parameter that we are selecting. How are we selecting the parameter? What are the limitations of the parameter? That should be known. What targets we are setting? That should be known. And the studies that we have conducted, I have shown here, the outcome studies. The outcome studies are quite costly to perform. But in this study, even the 2014, the last study that had been conducted to find out whether early gold adjuvant therapy is good enough or not, there also they have used centrifugal pressure as a method to monitor the fluid responsiveness. Had they selected the fluid responsiveness, the other parameter by which we can find out the fluid responsiveness, probably the result could be different. So how are we selecting the parameter? What kind of expertise do we have? What situation we are actually managing the patient with? The ward situation or in the critical care setup, depending upon the expertise, depending upon the equipment available, we should decide the parameter that we are selecting and then decide the action plan, decide the target, and then see whether the result is going to help us or not. Thank you so much.
I must congratulate Professor Samaddar for giving such a nice presentation to the audience, covering a wide range, starting from the simple PP monitoring and height of the patient and arm to be used up to the spectroscopy for monitoring. I know Dr. Samaddar since I was doing internship in Tata Main Hospital, and I saw him giving anesthesia and now doing management also. Now this session is open for discussion for any questions if somebody wants to ask. Sir, please introduce yourself and ask your question.
I am Dr. V.K. Thakur. With so many loopholes of blood pressure monitoring, so what are your take-home messages, sir?
See, you use blood pressure should be monitored. Now, what is the status of the patient that always should be seen? Suppose the patient is having cold extremity. Now, blood pressure is low. I have seen people using vasopressor to raise the blood pressure. People using vasoactive drugs to raise the blood pressure because they feel that the blood pressure is going to help in this patient. Now, so the take-home message is that pressure cannot be matched with the perfusion, the flow. These are two different things. In a normal patient, where the peripheral resistance is normal, in those patients, maybe the blood pressure is giving us, it's a good indicator, it tells you that no perfusion taking place. But where the impedance problem is there, peripheral resistance is high or peripheral resistance is low, blood pressure doesn't necessarily mean that the hemodynamic system is stable. So in critical ill patient, always view blood pressure with suspicion. It should be supported by other parameters. Whether it is justified, you rely on that particular blood pressure or not. In any given patient, the blood pressure that the patient is maintaining, whether that patient is serving the patient's need or not. Ultimately, it is the tissue oxygenation. Now, tissue oxygenation again, certain global parameters are there, certain regional parameters are there. Regional parameters, usually we rely on the clinical assessment. The global parameters are multiple, where you can monitor the SCVO2, you can monitor the blood lactate also, you can monitor the base excess to find out whether tissue oxygenation at global level is good enough or not. So blood pressure always should be judged against the background of the tissue oxygenation, whether the blood pressure is helping in improving the flow, improving the circulation and oxygenating the tissues or not.
Thank you.
Because see, in eclamptic patients or pre-eclamptic patient might have seen that blood pressure is maintained, it's high, but actually patient's oxygenation is suffering. So it's not necessary that the maintained blood pressure will ensure circulation and oxygenation.
Dr. Samaddar, we talked about in normotensive patient it's okay, but in hypertensive patient we require a higher
because they are used to a higher threshold. So
that is the basic idea that they are maintaining on a higher blood pressure to maintain their perfusion.
Yes.
We should keep them on a higher.
Yeah.
Any correlation or any formula or any relationship?
No.
with the present blood
It is
pressure?
very difficult to give a particular cutoff limit. Even 65 millimeter of mercury cutoff limit that is being used, we should always try to find out, I am recording the blood pressure correctly or not, what method I am using, what are the limitations of that method, the blood pressure that is being recorded is reliable or not. based on that decision should be taken, considering that the blood pressure recorded is correct. Now, again, what I have just now told, for the first question I have told that this blood pressure should be seen in the backdrop of the perfusion and the tissue oxygenation. Always try to correlate the blood pressure and any other parameter, the upstream parameter that you are monitoring, that should always be judged by the downstream parameter.
Any other simple question? Giving a fluid charge in the eternal question, colloid or crystalloid? Because you told 250 ml of colloid or 500 ml of crystalloid. Because I know we know that 1/3 only stays in blood vessel, 2/3 goes out in crystalloid.
When capillary permeability is high, then this colloid also will go out. So the debate is almost settled in favor of crystalloid, but in sepsis patient for resuscitation purpose 4 to 5% colloid is advocated, particularly albumin is being advocated, and even in liver failure patients also albumin is advocated. But for most of the patients, the crystalloid serves the purpose, and we also use crystalloid almost regularly. Colloid is very rarely used.
Any more questions from the audience? Thank you, Dr. Samaddar.